Hello. Good evening. I'm Dr. Sanjay Gogoi, and I'm
Hi.
the chairman of Urology and Kidney Transplant at Medanta Medicity Hospital, Gurugram. Today, we are having a small workplace Zoom meeting with colleagues uh, from Gurgaon itself and from few colleagues from Mizoram and Manipur. We'll be talking about the recent advancement in kidney transplant. With me today, we have Dr. Manish Jain. He is a senior nephrologist at Medanta Medicity Hospital. Hi, Dr. Manish.
Hello, sir. Good evening, everyone. We have Dr. Bernard Amer also from Kohima.
And also we have Dr. Jahau. He's from Mizoram. He's an eminent general surgeon and he is the owner of the Trinity Hospital over there.
Hello.
Hi, Doctor.
Good evening,
Jahau.
everyone. I'm sitting with Dr. Jehovan, one of our young surgeons at the hospital. So basically, my background is from, I was trained in the UK. I completed my CSSC in urology there. So I was quite involved in the transplant program in the UK and Ireland. But I came back to India in 2014 and started our own hospital. And Dr. Jehovan is trained in South India. So he joined us here as well. Good evening, everyone.
Hello, good evening, everyone, sir. I think I'm the youngest today. I'm a general surgeon, and I did my MBBS from Jipmer and MS in Government Medical College, Kozhikode. Then I did my SRship there. Then after that, I had a few trainings in laparoscopy and endoscopy and ERCP as well. Actually, I'm a general surgeon doing only general urology, like you all know, only stone diseases and all. So I basically do not have a big idea about latest advancement in kidney transplant, but I am ready to share the situation we have in Mizoram at present.
Thanks a lot, Dr. Yuva. We have a very senior urologist, former director of RIMS, Dr. Sekharjit Singh Sinam. Good evening, sir.
Good evening. Good evening, everyone. I must say that I may be the oldest in this team here. I'm 71 already. I'm not sure about Gogoi, but you look younger than me.
Barely, sir, a little bit.
Yes, right. As I said earlier, I passed my MBBS from RIMS, then went to Chandigarh, then AIMS, then came back, and since 1985 till 2019 end, I was there as head of department, then as a director, then as a professor of excellence for some time. And I had some exposure with kidney transplantation during my training in PGI Chandigarh under RBS Yadav, long time back. Then in AIMS with Dr. I.K. Dhawan. And when I went to UK, it was under the Nuffield Transplant Institute. And we had a lot of chances to do organ retrieval. It was all, cadaveric there. There was no living-related donors. And we used to do a lot of graft nephrectomies at the weekends, because weekends, none of them are available. And we are the only ones, Asians, who used to do that. And on weekdays, once a week, we were in the transplant program. Coming back home, our program started very late in Manipur. And I think we are proud to say that in the Northeast, entire Northeast, it was in 2023 that we started, even before Guwahati, who was ahead of us in other things, had not started. And now it is going in high speed with Dr. Sharatchandra heading the Department of Nephrology. Then we have a team led by Dr. I think Soleil and another nephrologist there in Jennings, and the Sri and Babina also are doing great. I think it will progress soon. And I hope the condition in Manipur or the entire Northeast improves, and we'll be in the same limelight as you people are there in Delhi. By the way, Dr. Adas Chaudhuri is my classmate from PGI.
Oh, I see, sir. Oh, he's a eminent gastroenterology surgeon, sir, and he's a great colleague to have with us. So thank you, sir, for your kind words and of introduction. And the next person, sir, I'd like to talk about from is Dr. Sharatchandra, sir, senior professor and head nephrology, RIMS, your colleague. Welcome, sir, in this webinar.
Yeah.
Few words from you.
Good evening to everyone. It's nice time to have such a Zoom meeting. And my full name is Dr. Sharatchandra Singh. People call me LK, Dr. LK here. And I did my MBBS from Maharashtra, Mahatma Gandhi Institute of Medical Sciences under Nagpur University. MD also from the same university. And I did my DM from Banaras Hindu University. And I was working in RIMS since a long time. RIMS Imphal since 1987, and now presently I'm working as the head of the Department of Nephrology. Thank you.
Thank you, sir. And I can see that Dr. Bernard has also joined. Hi, Dr. Bernard. Good evening. Dr. Bernard is a famous urologist from Kohima. Welcome.
Hello, good evening, sir.
Good evening.
Nice
Good
seeing
evening to
you.
all of you. My teacher, my guru, Sir Sekharjit is here with us. Good evening, sir, especially to you.
Good evening.
Yeah. So it's nice to have you there. I'm Dr. Bernard Amer. I did my MBBS from SV Medical College, Tirupati. That is in South India. And then after that, I joined my MS surgery from RIMS, Imphal. And also did my MCH urology from Imphal under the guidance of our teacher, Dr. Sekharjit. And in fact, he was my guide in two of my theses. So I'm very grateful. It's been already more than 10 years that I've been practicing urology now. And I do most of the endourology and laparoscopic also. And since I've been working in those fields, I want to upgrade my skills and, do into higher skills. So I'm in touch with Dr. Sholay from Manipur, Jain. And we are in the process of trying to start transplant here at Kohima. And some of the NGOs like Mohan Foundation has been help to us, and they are ready to extend their help to us. So I'm hopeful maybe in a few months to 1 year, maybe we will have good news. That's what we are hoping. Thank you for having me.
That's wonderful to hear from you, and I hope best wishes to you. I hope you have a quick start. A few words between me and Manish. We work together. We've been working together at Medanta from almost 16 years. 2010 onwards, we've been working together. And as you know, that Medanta is a big flagship hospital. In totality, we have the experience of more than 3,000 transplants, over the years. And the plethora of cases which is being done over here is extreme. I mean, from pediatric to, bariatric cases to all sort of cases that we have, the complicated. We did transplants in patients from patients suffering from neurogenic bladder or maybe some various congenital Kakut syndromes. We have been able to successfully treat them, build up their, the anatomy, and then do the transplant. So I think we can, with our experience, possibly share hands, and if in case you guys ever need any inputs from us, we are free to share. On a personal note, I cherish also that I've been able to start transplants in various parts of this country. I mean, before I came to Delhi, I have done transplants in other parts also. Like I've done transplant. Like I heard that Dr. Amer had actually passed his MS or MBBS from Tirupati. So I had worked in SWIMS Hospital, Tirupati. I was involved in the transplant program there. And I have been in for 5 years in Apollo Colombo. We did a transplant. I started there. Then I did in Calcutta. I have done in a few other hospitals in Delhi. The challenge stays, like having initiated transplant programs from the bottom in around 6-7 centers. The challenge of having, donor, right? So basically the disease donor program, despite all the pushes, despite everything we do, we have a challenge. So I hope all of you have good success in meeting your respective area of needs. Dr. Manish, would you like to add something about this challenge?
Sure, sir. I am Dr. Manish Jain, and I did my MBBS from PGMS Rohtak, then MD and DM from Chennai. After that, I did my clinical fellowship from University of British Columbia, Vancouver. And then I came back from Canada in 2010, and since then I'm in Medanta with Dr. Gogoi also. Currently, I'm a senior director and heading the unit. So we are doing all sorts of transplant. Like we have done the ABO incompatible in North India. We and the Gangaram hospitals were the one who did the first ABO incompatible, and we have done more than hundreds of this. Even a preemptive transplant also, when we see that the patient doesn't go for a dialysis and at that stage we have done transplant. And we have done successfully the very good number of the paired exchanges, A to B and B to A. Instead of the ABO incompatible, the paired exchange, the immunosuppression is less, the longevity is also better, and overall results are also good. But then if not there, then we will do the ABO incompatible also, depending on the titers. For a ABO incompatible, we use the glycosorb also, or the plasmapheresis and the rituximab, and then we follow. So we have done all sorts of transplant, and the team effort, the multidisciplinary approach, we have got a very good anesthetist team, the dedicated transplant anesthesia team, the transplant ICUs are there. We are running a transplant. I'm running along with Dr. Gogoi, the staff transplant nursing course also. That's a specialty nursing course. So we are training our nurses for a transplant unit so that they can work, and they are better than, not to offend anyone, but better than the few doctors also, because they know the protocols also, how to do. They know everything. So they're being trained in and out in this. And so we admit the patient a day prior. We do the transplant next day for a ABO compatible. By the day 3rd or day 4th post-operative, we shift them back to the ward, and by day 7, they are home. So we generally follow the patient. In first month, we see them weekly twice. Second month, we are seeing them weekly once. In third month, approximately depending on the requirement, but twice a month in a third month, and then subsequently for a year, monthly once. We are doing some outreach OPDs also, like Dr. Gogoi is also going, I am also going, Assam and other parts. So patient can come and see us there. So that also saves them a time as well as the money also to travel. So we are doing all sorts of transplant, and we are most happy to assist in whatever way we can do. So we are now more than 3,000 transplants and all related transplants. Though cadaveric program, as already discussed, is not good in our part of the thing. So that is still going on, but like it is definitely going to evolve. Back to Gogoi, sir.
So thank you, Dr. Manish. The another important aspect of transplant, because we have in this forum bearing one senior nephrologist. Most of us are surgeons over here, and two nephrologists, Manish also, through nephrology for surgeons. So I think if you can just steal a few moments from the nephrologists and talk about the surgical bits of it. I'd like to comment over here that over the years, the surgical skills, as Dr. Manish said, it's not only the surgeon which is important, your assistant is important. And so are other people who are behind the scene. Like a very good radiologist, you'll have to actually have a good radiologist in your team who can actually do very wonderful Doppler scans, especially who will not deny coming in the middle of the night to do the scans to see the vascularity. And also in cases where you have an obese maybe donor, not the very right type of donor, but of course we have to be sometime taking them in. And we need to know the degree of the atherosclerosis in the vessel. And also the recipient, sometimes we have got bulky recipient, despite bariatric surgery, they do not lose weight. Sometimes we end up opening them up and we find that the internal iliac or the external iliac are thrombosed.
Sir, you are not audible.
Oh, I'm so sorry. Am I audible now?
It's audible, sir.
I can hear you. I can hear you.
Okay, fine.
Okay.
Yes, sir. Yes,
Audible,
sir.
sir.
Please carry on, sir.
Yeah, I was saying that having a good radiologist is very important, and I'm sharing here that many times we have actually opened up the patient only to find that the receiving artery, like the external iliac or the internal iliac, are badly thrombosed. I remember very vividly, like we had a patient from Burma, Myanmar, and it was I think it was a minimally invasive transplant. We were doing a robotic transplant for that lady. And just because we did not have a good preoperative imaging, we just relied on a Doppler scan, which we mentioned normal study of the pelvic vessels, we got befooled. So later on, I made a protocol that, in sort of donor recipients where we have less than optimal BMI or maybe little other systemic diseases, go for a CT scan assessment of the pelvic vessel, which is something which we have learned over the years. I like to hear from you, sir, in your part of the country, our part of the country. Do you also get sometimes people with very abnormal blood vessels where transplant is difficult to do? Maybe, sir, Dr. Sinam can say something about that. Please unmute yourself, sir. Please unmute yourself.
Fine. I mean, transplant is quite new in Manipur, and we haven't had too many problems. As Dr. Sarat has said, the complications have not been very, very great. But we have had occasions where there was difficulty in getting good vessels for anastomosis. There was no case where there's an obstruction of the block of the vessels in the recipient. As far as I can see, I do not take part in all the things. It's only in one center that I take part right now. Maybe that we are selecting our patients well, and we of course do all the investigations, as you said, CT scan, but with little, we do not want to expose patients to radiation and contrast before the procedures. They already compromised people, but we would do in cases where we suspect. Thank you.
Yeah. So anyone would like to add more about this? Proper preoperative assessment of a recipient.
No, as you told rightly said, sir, that radiology is very important. So for a donor also, the CT renal angio is done in all the donors so that the correct assessment of the vessels can be there, how many arteries, how many veins, so that the surgeon can plan accordingly. And then the Doppler is also important for the recipient also. Suppose they are having a femoral cannulation or something. In those patients, we can get a CT urography for the even for the recipient also. And once they are on dialysis, nothing to worry about the contrast also, because already they are on dialysis and you get a better lineages as well as a better definition of the vessels. Otherwise, the iliac femoral Doppler is sufficient enough with a good Doppler radiologist. Otherwise, if any doubt is there, definitely you can go for CT urography. Already these patients on dialysis, and that is going to help the surgeons a lot during the surgery. Isn't it, Dr. Gogoi?
Yeah, that's very important. Here, another point I'd like to add also that, many times male CKD patients in the age group where they have BPH also, they would come to us. And since they are anuric or oliguric, their obstructive symptoms are not even reported. They will not say anything. I mean, only to realize that after transplant, they are having, gross prostatomegaly-induced retention of urine, and we are having to do a endoscopic prostate treatment like TURP or a laser prostatectomy, maybe 3 months, 6 months after surgery. And many times they end up having secondary complications like urosepsis and all this stuff. So what I have done recently over the last 5 years, that since if they are totally oliguric, obviously I cannot evaluate them very well. Doing an aerodynamics is something which I have started doing if I have a very strong suspicion of outflow obstruction. Well, now in the last, say, year or two, what I have done also is very strangely, if I have a prostate which is more than, say, 50 grams in a person who is in the age group, I have actually, gone ahead and done preemptive TURPs in some of them or preemptive laser prostatectomies in some of them, so as to prevent subsequent post-transplant endoscopic surgical treatment, which becomes a little risky in view of chances of UTI and other problems. This is something which is not in the textbooks, but I think I would like to share with my surgeon friends here. Be alert about not focusing only on the kidney. Be sure that you are going to fix the kidney in the bladder, which is going to be of the right health. It should not be obstructed so as to not cause graft dysfunction. Otherwise, the nephrologist will send you the patient back and think that there is graft hydronephrosis. And then we again start evaluating. This is one thing which I think I would like to share with my friends over here.
No, definitely, sir. We would like to hear these type of things because which are not in books, but this experience makes a huge difference. And our CKD patient, especially as you are telling males patient, most of the time, if they're on a long-term dialysis, vintage is like high. So they subsequently become anuric. So you can't make it out whether the prostate symptoms are there or not. So once you have done the surgery, then the retention happens and all these things. So definitely this experience is very important, sir. Definitely.
Right. There, I think can I just say one thing?
Please, sir. Please,
Yes,
sir.
sir.
There comes the importance of urologic assessment properly. There are centers where I've visited, and there is sort of a perfunctory sort of referral to get the permission and go ahead with the thing. But I think the urologist should take initiative and do proper assessment that you can so that you can exclude outflow obstruction and do not land up with problems and urosepsis too. I believe.
Yes, sir.
Sir,
Very
can I
important.
ask one question, sir?
Please go ahead,
Yes,
doctor.
Yeah. So we usually have extensive investigation for the recipient. So, like Sir said, it is important to have a proper workup of the recipient. And when it comes to the donor, since I have not done any transplant from my side, what are the basic imaging techniques or say radiological investigations you order in a routine case? Is it CT urogram alone or CT angiogram also, or what are the investigations are done for the donor apart from
Well,
the blood matching?
yeah. So, if you can speak to your radiologist and create a protocol, we say triple phase CT or transplant donor CT, something you can name it anyway, evaluation. So what basically we do is, the same contrast when it is in push, we can take the arterial phase, the venous phase, and the excretory phase. We don't need a dedicated arterial because nowadays most CT centers are having 128 or 256 slice CTs. And we can very well reconstruct the arteries. We don't need a dedicated, I would say, CT NGO in all cases. That suffices
So
actually.
triphasic CT is enough,
Yeah,
sufficient.
Yeah.
Okay.
sufficient.
Yeah, Dr. Amer, first of all, as you know, we'll do in imaging ultrasonography. And once that is fine, then you go for a DTP renal scan. So we do it in a phases. First, you do all the blood tests, urine examination. Once the proteinuria is not there, then you go for the specialty examination like a gynec evaluation, cardiac evaluation, psychiatric evaluation, and further, like if more than 40, a mammogram also for a females. So after that, you go for an ultrasound abdomen. That's a basic test. And then after all these tests are normal, then you go for a DTPA renal scan, which will tell you a split renal function of GFR of both the kidneys. Once these things are okay, then we go for as Gogoi sir has already mentioned, CT also to determine about the kidneys and the vessels, and then you have to go for that.
Okay. Thank you, sir.
So, Dr. Gogoi, one question.
Yeah, please.
Since now you have done quite a few robotic cases.
Right,
In
sir.
your opinion, what is the difference to the patients?
What is?
Yeah.
What is the difference in morbidity
Okay.
to patients with robotic versus minimal?
If you so allow me, I'll just show you a few slides if you can allow all of you. I'll show you a few slides. Just a second.
Sure, sir.
If I can.
Sir.
Are the slides visible?
Yes, sir. Visible, sir.
Yeah,
So, you know what? It's a very important question. See, now this is what we have in a standard kidney transplant, right? Oblique wound in the abdomen. So we have people of various composition, fatty people, previous surgery, previous hysterectomies, previous appendectomies. So we are challenged by the fact of drug-induced poor wound healing that tacrolimus and prednisolone prevents the wound healing. And we have something like say 7.8 or 10% incidence of surgical site infection in transplant patient. So when it comes to minimally invasive transplant, I have these two pictures over here. One on the left is a robotic kidney transplant, where you can see that graft has been put by the periumbilical incision, and rest are these small 8mm ports through which we have done this procedure. One on the right is a person who has been operated by laparoscopic kidney transplant. This was, of course, in the previous days. This one I operated in 2017 and 18. Is an obese gentleman. So, and in all these cases, graft introduction is from a small wound over here, and in the other one in a small fenestril over down there. So basically, for the patient, the only benefit that comes is the less chance of surgical site infection. We have another situation in robotic transplant where this lady, very eminent politician's wife from a foreign country, she did not want a scar. So we did a natural orifice kidney transplant in her where we had put the graft through the vagina so that, we don't have a scar. Of course, this is an aesthetic procedure, so I'm not trying to sell it to you. What I'm trying to show is that, people who are obese and something like when you have a BMI which is in the higher than say 30, and people have tried doing everything to, bring down the body weight, and despite that, these marginal recipients have to undergo transplant. In those cases, we would rather have a person being operated with minimal wound size. So now we don't want this. And as the transplant program proceeds, many of us will see such big wounds which are not healing. They will require repeated suturing. Now, when we do the robotic transplant, sorry, I'll just skip through the slides. So this is what we get sometimes. You can see the number of X in the pajama in the left. So she's a hugely obese lady. Looks like she's a male because of the punch away. This is not a scrotum. This is actually obesity, gross obesity, post-bariatric surgery. She had an abdominoplasty and did everything, but she wanted a transplant. So if you do a transplant in this patient by open wound, you know the consequences. So when you do it by, say, robotic procedure, all we have is a scar of this size. So we can have the kidney inserted through this and rest of the surgery done. So we save the big incision in the wound. So possibly the only situation where robotic transplant really works out, and that's what the literature supports, is that in cases where a person is grossly obese, we can actually provide them the benefit of preventing a surgical site infection. So I think have I answered your question?
Yes, thank you, sir.
Any other? I mean, we don't have a pediatric nephrologist over here. So another point, Dr. Manish, of course, handles some. I would like to say that we should also keep in mind that many of our pediatric patients who have CKD I'm talking of our country as a whole. They end up being on peritoneal dialysis for a long time, recurrent infection, peritonitis. And it is sad to see that many of them actually die off because we are not treating them, and we leave them with a nephrologist, care, and we don't have a pediatric backup, good pediatrician looking after them, nutritional requirements. So I think those are also our patient population in our society where we can actually treat them. Initially, of course, we can treat them with a good peritoneal dialysis program till they become of proper sort of size. And then, our experience in pediatric transplant, I have done children as young as 3 years and had great success in them. And I'm happy to share that the outcomes in pediatric transplant after the initial, say, 3 months is excellent, actually. They do very well. And I think if at any time you guys will need our help in settling, such cases, we'll be there to help you out also.
Even for robotic transplants, I would like to add one more line. In north part of India, most of the females wear saris. So for them, so the abdomen, it makes a huge difference. If they have a big scar, they'll be like afraid of wearing saris or like going in the public. So the robotic transplant helps in that's a big help for them. No scar and nothing is visible. So that confidence level goes very high. Even we have seen for males also, though like a normal one also, they are preferring this because of the scars. So they can go for the other activities also very easily.
Okay, sir, let me ask you one more question. When you do the robotic transplant, we go through transperitoneal, or the kidney is kept extraperitoneal or intraperitoneal?
Yeah, very good question. So in the initial learning phase, as you would, I would like to share also with you that the robotic kidney transplant program was started completely from scratch in Medanta, Medicity, by my previous chairman, Dr. Rajesh Elavat sir, and his team from the United States, Dr. Mani Menon and his team. So initially, when the transplant program started, the whole logic was to put the graft intraperitoneally, like we do it in a pediatric patients. Pediatric transplant is always intraperitoneal because we have to access the artery, the aorta and the IVC, so we do that way. Over the years, what we have understood that in an adult, even if you're going intraperitoneal placement, after the placement of the graft, we can actually have almost 80% coverage as an extraperitoneal graft. What we do is we put after anastomosis, when we sort of rotate the graft towards the right iliac fossa, so we cover the base of the graft with the parietal peritoneum of the bladder, as well as of the descending colon. Right? Sorry, not descending, ascending column. That's ileocecal junction, the peritoneal reflection of the ileocecal junction, and the reflection onto the median umbilical ligament and the bladder. So that is brought together just to create a space for the graft outside. Of late, this modification of placing the graft outside the immediate peritoneal cavity has worked very well. How it worked, because also the amount of drainage which becomes a little difficult to wound drainage, which is difficult to judge in standard interperitoneal placement because large intraperitoneal volume. When we started doing it, we are able to have more of a localized collection in the right iliac fossa because of the omental reflection and placement. I hope I have answered your question.
Yes, sir. Thank you.
So, Dr. Manish, you want to tell us something about your experience in the ABO program?
Yeah, ABO incompatible, once we started it, like the first one was in 2013-14, the titers was 512. So how we see the titers, anti-A or anti-B titers, it comes in a, like I think 1:4, 1:8, 16, 32. So that 512, later we realized it was a high titer and he required lots of plasmapheresis. So what we do basically, depending on the titer, up to 256 is good enough, but 512 and 1024 also we have done. But the chances of rejection and infection definitely goes high in the initial period. So what we do, will give a rituximab injection either 2 to 4 weeks earlier than the transplant. And depending on the titers, we start the immunosuppression 2 weeks before. And then we admit the patient and start the plasmapheresis. Suppose they have to go for a transplant, 1:128 is a titer. So what happens, you do the plasmapheresis, next day the rebound will be there. It will come down to 32 and next day it can be 64. So 3 to 5 sessions will be done. And once the titers are less than 8, we can take them for a transplant. The other option is a glycosorb, where we have to import the column from outside. That costs somewhere between 4 to 5 lakhs. Though it is, they don't recommend it to reuse, but we reuse it. So after that, the plasmapheresis sessions will be less. And then we take them for a transplant. We monitor their levels. So definitely the first month is crucial because of the infection as well as the rejections also. And still, since they are much more immunosuppressed as compared to the ABO compatible, risks are more. But post 1 or 2 months later, their survival and the rejection rates are almost same as the ABO compatible. So we have done a good number of ABO incompatible transplants, and touch wood, all are doing well.
Thank you, Dr. Manish. If I may add here that another important experience you will all have is having to manage patients who are very eager to get kidney transplant, but then you realize in the urological assessment they are having neurogenic bladder. So many of the centers are actually routinely refusing kidney transplant in a patient with neurogenic bladder. So in the last so many decades, what we have learned is we had a person with congenital agenesis of bladder. We made a neobladder in that girl with a mitrophin of catheterizable stoma. We did a transplant for the child in the year 2012. She lost the first graft because of poor compliance, and then in 2016, we did the second transplant, and that kidney is still working today. And the girl who never had a bladder, we made a neobladder, and now all along she is on intermittent, bladder self-catheterization with the mitrophin. The very fear that CIC or self-catheterization and emptying the bladder will lead to increased incidence of urinary tract infection has not shown, it has not been seen in our, I think, experience. Because what these people were doing is we are having the catheterizable stoma in the abdominal wall and not in the perineum. They are not using the perineum or the urethra to cannulate the bladder. They're having the mitrophin of the abdominal wall. So I have done almost 72 of these sort of transplants in the last, this period of time of 30 years. And most of them have been, augmented bladders in pediatric patient. The last one we did, I think our patient we did somewhere, I think in the month of, I think last year, May 2025. He's a young boy who has now gone off to Edinburgh to study engineering. He also had this sort of, bladder. We did an augmentation, and they do as good as a normal other kidney transplant patient. So I think, our greatest learning in these years is that no one is unfit in terms of having a congenital anomaly of the lower tract not to get a transplant. Be bold enough, do an augmentation cystoplastic, bring down the blood pressures, and then we can have all this, benefits of transplant. We can offer it to them also.
As Dr. Gogoi is saying, this is a young boy who had a neurogenic bladder from the childhood, and he was suffering. He was doing CIC also. And once, like, he was on 3 antihypertensives, and ultimately his kidneys failed and he was on dialysis. He had a very, really hard time. He was on 5 antihypertensives and his blood pressure was not getting controlled. So the family was initially reluctant also because he had to undergo this surgery also. Maternal procedure was to be done. But he underwent that. At that time, he required transfusion also. But 2 months later, 3 months later, we did a transplant. And touch wood, right now he's doing very well. Sir, I think he's doing CAC once or twice a day and with only 1 antihypertensive. And he's doing his master's also abroad. So the scenario changes after things. So there is nothing like a successful kidney transplant. And definitely, until unless we are confident enough to do it, though the family was also, they have so many doubts, young boy with a thing like
Yeah.
require CIC also,
Mhm.
so many antihypertensive, suppose it fails, but ultimately that touchwood he is doing very well.
Yeah. So,
So, sir, can I ask questions?
yeah, please.
My question will be very simple and very plain, as I'm not a urologist, but a few of the patients who I met in OPD, they are concerning about the financial thing. So just now you mentioned about the robotic transplant and all. So I'm not expecting about the exact rates or as such, but I just want to know what is the
Average
robotic average cost? Is it 1/3 or 2/3 extra to the original open or like that? How will I communicate people
Yeah,
if they
open.
if I suppose if I want
Yeah,
to
I'll
reach to
just
your
tell you about
center?
generally about all the transplant, like what is the cost, and then Dr. Gogoi can add to it. For investigating donor and recipient, if you do it in a normal course, it costs somewhere around 1.5 to 2 lakhs. Suppose someone requires an angiogram or a other special investigation, that is different. Otherwise, mostly like because we do a HLA cross match also, that's a costly. So it approximately will cost 1.5 lakh. That can be from 1.25 to 2 lakhs. And the transplant package along with induction is 7.5 lakhs. That is for both the donor and the recipient surgery. So that includes the immunosuppression also for a week stay. And suppose that we have set up the protocol, like one protocol biopsy is included into that if by chance they are required. Not protocol biopsy is included, that's also not cost extra charge. One dialysis is there and the battery of tests are there. But if they have to go for a robotic, I think, sir, 1.5 to 2 lakhs is extra cost.
Yeah, roughly around say 2 lakh will be extra. It's a very good question, Dr. Larin. So basically, in robotic transplant also, there are different centers doing this in a different way. So if you can, go around, there'll be some centers which use a special tool to put the kidney inside. There is something like a special port which is they place next to the umbilicus. So that used to add to around say 70,000 rupees. So we have given away all that, and we make a small fenestrel incision in the groin, in the abdomen, and put the kidney inside through that. So now that has made our program roughly around 2 lakh rupees, or maybe a little more than that, expensive than the standard transplant.
So you can say like 1.5 to 2 lakhs for the investigation.
Yes,
In
sir.
a routine transplant is approximately 7.5 to 8 lakhs, and that will come with somewhere 9 to 10 lakhs.
Yeah.
One more question. What about the follow-up programs you follow in your center? Like how frequently they should come up to? What years? Those
Like,
basic questions are the one they ask in the OPD.
yeah, so first month we see them twice. I'm talking about the recipient. First month we'll see them weekly twice. Third, after 3 weeks of the surgery, the stent is removed, which is good. Then the second month we will see them weekly once. Third month, almost 15 days once, and then monthly once for a year. After a year, 1.5 to 2 months, we see them up to 2 years, and then they can come up to like every quarterly 3 months in a like from third year onwards if everything is going correctly and if they don't require like suppose track levels and the things are there, but these levels are being done everywhere now. So donor, you already see them after at the time of like 1 week after the discharge, then 3 months after discharge, and then yearly follow. So that is the general follow-up is practice. For a donor, like since they can have a proteinuria or a blood pressure, they should monitor their blood pressure. We do the urine protein analysis after like spot urine albumin creatinine ratio after 3 months and then yearly follow-up. So yearly basic tests are there. You do a hemoglobin, creatinine, ultrasound after a year. And I think after 3 years, you do repeat ultrasound or not required, sir, in a donor.
We prefer to do one maybe a couple of months, years later.
But recipient has to be in a regular follow-up and regular
And
medical.
last question, for the later part of the follow-up, would you rely on the local doctors which we have, or you need your expertise every time?
Definitely. We always tell them to be in a touch with a local doctor because you are the one who will be helping them if they have any problems. We are sitting far, so that's much more easier for that. Connect is very important. Suppose you are a surgeon and they have anything, you can directly speak to Dr. Gogoi and he can guide you accordingly. And if any complication something there, then you can send them back to us. But you are the primary physician and the surgeon who will take care of them. And
I wholly agree with Dr. Manish, and I think it's the most important part of the successful transplant outcome for a patient. If the patient believes only the treating hospital is going to treat him for life, it's never going to be successful. Neglect. I mean, some people will wait for an infection to think that finally I'll go and get it sorted out, and many times it becomes aggravated. So it's very important that local doctor is very much in the pool in the treatment paradigm.
See, till the transplant is done, it's a multidisciplinary approach here. But after the transplant, it's a like multi-centric approach. We have to be in touch and we have to go hand in hand. So we always tell them also, like for our transplant recipients also, these are the basic drugs which you can take. Suppose you have a URI is there or this. So take this drug and see a local doctor, whoever is treating you, physician. That is the most first contact is the local physician and the surgeon. So that if required, you can admit and treat them. And if we are always there in that way to help and to aid in that way.
That's a very good thing that you're suggesting, that doctors referring the patients to your center or some other big centers should also take initiatives to look after the patients when they come back with your guidance. I just want to ask, please tell me.
Yeah, that's the best thing, sir. It's the best interest of the patient also, because then these patients are the ones, suppose they're going to a doctor who doesn't know about that kidney transplant, they won't treat him. So that contact is very important with the primary physician. And in that way, we have a confidence between us also, sir.
Right. Yeah. With your experience, Dr. Gogoi and Dr. Jain, I just want to know your protocol for a patient, a recipient who has acute kidney disease, I mean AKD, in early phase, who are likely to go into CKD, maybe because of reperfusion injury, or maybe because of the ischemia time was too long, or maybe some other factors. What is your protocol? If you find somebody going into that, creatinine clearance coming down, creatinine rising up, and sort of thing, what is the protocol that you follow for this patient?
Sir, this acute kidney injury, acute graft dysfunction after transplant is not uncommon. We see them. So mostly can be like once the stent, we remove the catheter on the POD5 and stent on the POD21. So they can get a urinary infection also. And if they have a retention, then as Gogoi sir was telling, a male patient who has got an obstruction, they can have a urinary retention and then the catheter creatinine can go. So we have to rule out these causes. Initial stages like POD3, 5. Now hyperacute rejection is not seen so frequently, but acute rejection is there, and which can be a cellular rejection or an antibody mediated rejection. Then we have to do a graft biopsy and treat them accordingly. Then that's why the meticulous tacrolimus level, CNI, we use tacrolimus now. Cyclosporine is being used less. So that tacrolimus level is also very important, because if level goes high, the toxicity can be there, that can lead to a graft dysfunction. And if level goes down, then the rejection can be there. So that's also a problem. Then the earlier phase, BKV virus, CMV virus infection, because their immunosuppression is high. And if suppose we are giving a induction, heavy induction, that's also a problem. So we use a thymoglobulin induction, but as recommended is 6 milligram. We don't give 6 milligram. We give maximum of 3 milligram per kg in 2 divided doses. That too for a spousal transplant, or it's a highly sensitized patient. Otherwise, we can do a basiliximab also. That doesn't cause so much infections. So we can give that also. And then we have to keep a low threshold for the biopsy also, so that we can find it out what is the reason in earlier phase. If it's a later phase, we can just keep a watch also, monitor the levels, see the proteinuria, and then the recurrence of the basic disease can also happen, sir. Like MPGN is there, IGNF, so all these diseases can recur also, so that we come to know by the graft. So there are various causes which can be there. And one of my patient was there, he was prescribed a tacrolimus of 2.5 and 2.5. By chance, his wife missed 2 milligram of the dose. He took only 0.5 for 3 days. He came with a high creatine. So then I asked him what was the dose he was taking. No, I was taking correct. So many times in the first few 2 weeks, I'll tell them to bring the drugs also, how they are taking. Because in hospital, POD 7 till we are discharged, nurse is giving a medication. After going home, they have to be very careful regarding this medication, so that meticulous education of the patient attendant and patient is very important. And we keep them like Dr. Gogoi also will agree. So we generally suddenly will ask the patient also how many milligram this dose you are taking. So we tell our staff also to educate them properly. These 3 medication, your tacrolimus, your mycophenolate, your steroid, these are the doses, and you don't modify it accordingly. No, you can't misjudgment cannot be there. And sometimes we tell them for tacrolimus also, don't change the brand until unless it's like warranted. If you're changing the brand also, they should monitor the tacrolimus level also. Then once they change it.
Sir, one more question. Even though this is a medical discussion, but I want to ask a question as a layman, a layperson. My neighborhood, I have one police officer who had his transplant rejected twice within 15 years. So what is the longest transplant patient who you followed who doesn't have any transplant rejection for how many years that gap has?
I have a patient who has got his transplanted done in, one is 1998, one is 2002 also. So these are the patients I'm following. Even a cadaveric transplant also, disease donor, I have a patient who was transplant done in 2008. And I think Dr. Gogoi might be having much more. So we have
So it's a very
got-
good question. Good question. But see, the most important point is also who was the donor? What was the age when he donated? And what was it a marginal donor? And those things are also important. So I think the answer is quite, it varied. But most of the time we see people who are living for a long time with the graft.
Yeah, see, the chronic rejection can happen. Then other than that, drug toxicities can happen. Recurrence of the basic disease can happen. But in our country, what is the most common? After a few years happen, they become they have a callous approach, non-compliant. They'll miss the medication. The timing and the regularity of medication is very important. So that need to be reinforced again and again. And like after a few years, 7 years, 8 years, 10 years, they'll think, oh, one dose is missed, what is going to happen? No, that's important. Many times we see the most common cause of getting a transplant loss in our thing is a non-compliant with the medication, whether it's a cost factor or a callousness or a whatever we can say. Sir, please unmute yourself, sir.
Okay, I have another question, which probably any one of you or Dr. Gogoi could take it. What are in your experience with so many cases that you have done, incidents of vascular anastomosis, narrowing, stenosis, requiring redo surgery, or the uretrovesical anastomosis needing some sort of intervention?
I'll take this question. Very important question, sir. And I think more than the vascular complications, is the uretrovesical anastomosis or even BK, virus infection leading to urinary complications. They have been sort of the most difficult ones to handle. And luckily for us, we haven't had very many urinary complications in-house because we have been practicing the method of anastomosis, which has been sort of standardized as a modified Leach-Greger anastomosis with interrupted sutures of the uretrovesical. So we are having and 100% stented anastomosis. DJ stent is placed in all our cases. So I think those are the reasons where we haven't had many of this complication, but we do get referred quite a few patients with ureteric strictures BK virus led or maybe ischemia led. So in those cases, they are difficult challenges. But what we do is the best way to manage in those cases to do a native ureterostomy, whereby we, as you understand, that we use the native ureter on that side and anastomose it to the pelvis. And only catch over there is that kidney on that side, the native kidney on that particular side, we need to tie up the proximal ureter. So sometimes that native kidney, if it has some glomerular output, obstruction, and it may require a nephrectomy.
Right.
Regarding the vascular complications, standard over here in our hospital has been for the arterial anastomosis in terms of both anastomosis to the internal iliac artery and also to the external iliac artery, or even to the common iliac artery. So what we do is one posterior layer, which is continuous suturing, and anterior layer is interrupted suturing. So we have been having this sort of protocol from the last, say, 16 years in this hospital. And most of our trainees who have learned from us have been practicing the same method. So probably by giving the intermittent stitches in the anterior, anastomosis, we are preventing the purse string effect and thereby also preventing the chances of stenosis, the mechanical stenosis. But if someone has atheroma in because of the systemic disease of atherosclerosis, they do come with delayed obstruction. And then we get them sorted out by the interventional radiologist. We do balloon angioplasty. Sometimes we have been very successful in managing those cases and extending the graft life by doing angioplasty also.
Right. Good.
It was a nice interaction between both all of us together. I think we have almost completed 1 hour of this conversation. And is there any more questions, sir? Otherwise, I think our session will be ending in a couple of minutes now. Is there any more questions, sir, we would like to take up?
It's not a question. I'd just like to comment on this.
Right, sir.
Some of my Northeast friends might not like the comment I'm going to make, but I think what it comes down to is, even in India, we have to start really looking at centers of excellence. Let it be any specialty. It is good to be able to do things in our centers and in our states, but the quality of surgery, the quality of aftercare, this only grows when we have centers of excellence. So when I was in Ireland, my hospital, Beaumont, was a center of excellence for renal transplantation. So in a small country like Ireland, the success rate is quite high. And India is a huge country, but I think we should have regional centers of excellence even for transplants. And again, in India, affordability is a big issue. But say that, yes, we should all try to start a transplant program, but we have to realize that it's the multidisciplinary approach and the backup, which is so critical in the first month of post-transplant, It is not a surgical complication. It's our nephrologist friends and our critical care. We need more than the surgeons. And I think we have to realize this as well,
If I may add one point over here. So the concept of, in transplant at least, the concept of me is not right. Me to we is where we should progress. I mean, we should do it as a team rather than me doing everything. I think the friendship between the nephrologist and the urologist is the most important, component in having a successful transplant program. If the surgeon starts, interfering in the immunosuppressive protocol or maybe even selection of recipient donors, then probably we are diluting ourselves. Let's concentrate on our part of it. Let the nephrologist manage the systemic disease of the patient, as well as other more pertinent, important thing like drugs toxicity, immunity rejection, and and the infection that follows after transplant. There's a huge plethora of complications with the nephrologist handle. And as a surgeon, you will never have time to handle those things. Some of my colleagues have been very passionate about keeping the whole program under their wrap. It's like they want to make it a sort of surgeon-centric program. And those people actually end up burning their fingers and then realize that, okay, it's a team effort eventually. So in fact, in our team effort, we also need ID specialists, infectious disease specialists. We need very good critical care team who will not deny, getting involved in the middle of the night with some intervention. So you have to, as you said correctly, it's a center of excellence with center of excellence people around you, nephrologist, pathologist, surgeons, critical care, even the nurses in the dialysis center, as Dr. Manish correctly said, including the nutritionist, including the hygiene people, all are involved in the proper outcome of a transplant patient.
A good cardiologist, endocrinologist also, because see, after the transplant, they will be on steroids and their sugars will go haywire. And most of the transplant, their basic disease is diabetes. So that also need to be a good physician in a place where who can handle the sugars very well. And most of this, they have a metabolic syndrome, underlying cardiac problem will also be there. So it's a collective approach. And regarding the cost, I'll comment like many of our CKD patients who are the youngsters, they won't know that suddenly they will come up with a CKD. And what we see, many patients, once they are having a CKD, after they'll get a medical insurance. So the education regarding the medical insurance is also not there. So if they are getting an insurance at a timely interval, like initial stages, so that many things can be covered. So that is also there, like education is there. And we see like even a good educated, good affordable people also doesn't have a medical insurance. So they should have an insurance once, and there should not be any like falsely telling that after they get an illness, they will hide. Then that's a problem. We should take a medical insurance also. I'm not promoting that in a wrong way. They should take a medical insurance in a timely matter and with revealing all the illnesses. So that also going to help a lot.
Can I add just one point?
Sure, sir. Sure, please, sir.
The relationship between and the friendship between urologists or transplant surgeons, for that matter, and the nephrologists is inseparable. We have to have good relationship, and I believe we also should have a good friendship with a good interventional radiologist who helps us at times of need, and that's a very important thing because they should be available when you need them. There can't be just somebody who says I can do it tomorrow. It is now that you need them. So we
Yes,
have
sir.
that's
Very important, sir. Very
Our
important.
center, sir, we have like 24/7 availability of all these specialties. And for Dr. Gogoi and myself, we keep a very low threshold. Even in the middle of night also, we are not hesitant to come over. And recently we had a one case, so I called Dr. Gogoi at 1 o'clock and he was there at 2 o'clock and the patient was switched to the OT. That has to be there. We have to keep a very low threshold for these things because for them it's a life, sir.
Yes, true. That has been a very good discussion, I believe.
Thank you, sir. I hope all of us learn from each other's experience, and we like to carry our, association. And whichever way Manish and I can be part of your program, we are very much with the institute's permission, Medanta's permission, we can join hands. And if you ever happen to, have anyone needing some specialized care, we can only assure you that we'll do the level best, whatever we can offer with our years of experience in the center. Thank you for joining us today.
Thank you. Thank you.